Hola, ¿qué tal? Muy buenas noches y bienvenidos a todos. Good evening, Dr. Matthias Holdhoff. Welcome to our first Expert Talk of 2023. Bienvenido al Dr. Matthias Holdhoff al primer Expert Talk del 2023. Mi nombre es Alejandro Egea y soy el director de educación médica de la División Salud del Grupo Montecristo. Mientras que esperamos a que las demás personas inicien, vamos a ir haciendo un breve repaso tanto de la trayectoria del doctor Matthias Holdhoff. Luego haremos un mensaje gracias a Radioterapia Siglo XXI, que es el patrocinador de este evento, y les estaremos contando un poco de las demás iniciativas de educación médica que tenemos planeados para este año 2023. Este es un evento gratuito, abierto a toda la comunidad médica y adicionalmente en el que esperamos poder contar con su participación y comentarios en los últimos 15 minutos de la conversación. Hoy tenemos al doctor Matthias Holdhoff, gracias a una iniciativa que desde hace 4 años el Centro de Cáncer y Hematología del Hospital Metropolitano viene potenciando y en el que adicionalmente estamos buscando poder hacer conversaciones de índole académico y clínico para poder discutir y actualizarnos. Así que muchísimas gracias. Quienes ya están conectados, les agradecemos también indicarnos de qué especialidad, de qué hospital, de qué universidad nos están acompañando. Y en unos minutos vamos a empezar a hablar en inglés, que va a ser el idioma oficial de nuestra conversación. Dr. Matthias Holdhoff, thank you for joining us tonight. I'm just going to do a brief introduction while we wait for the other guests to come over here and join us. Parece que varias personas compartieron un mismo link y tenemos a varios Alejandro Egeas conectados, así que si pueden revisar su nombre y actualizarlo sería de muchísimo provecho. Hoy como indica aquí en pantalla, tenemos al doctor Matthias Holdhoff, que es codirector del Brain Cancer Disease Group y también del Sidney Kimmel Comprehensive Cancer Center de Johns Hopkins University. También es profesor asociado en oncología en la misma universidad. Y justamente, ¿verdad? El programa de Expert Talks es una iniciativa del Hospital Metropolitano en el que buscamos en cada 6 a 8 semanas poder estar invitando a expertos nacionales e internacionales a poder actualizarnos y a discutir casos de interés. Esta vez tenemos en la situación de oncología, pero vamos a estar rotando durante el año con un apasionante e interesante programa académico que nos va a permitir estar conversando de diferentes temas. Antes de iniciar, les vamos a poner acá un pequeño video de Radioterapia Siglo XXI, que es nuestro patrocinador de este evento. Así que aquí vamos a compartirlo. Y luego le voy a dar la palabra al doctor Andrés Viernik, nuestro director del Hospital Metropolitano, para que haga la introducción.
Con más de 20 años de trayectoria siendo la mejor opción de tecnología en radioterapia, pioneros en la aplicación de tratamientos radiantes en el país. Hoy nos renovamos con tecnología de vanguardia única en la región. Presentamos ExactTrack de BrainLab, nuestro nuevo equipo. Sistema de monitoreo basado en rayos X en fusión con nuestro acelerador lineal, capaz de detectar movimientos sin trafracción del tumor durante la irradiación. Algunos de sus beneficios: monitoreo y aviso en caso de desviaciones, tratamientos más rápidos, mayor precisión y exactitud, alineación automatizada en tiempo real. ExactTrack de BrainLab, tecnología de primer mundo al alcance de nuestros pacientes. Somos radiación de alta precisión, una esperanza de vida para el paciente con cáncer.
Muchas gracias, y antes de darle la palabra a nuestro director, el doctor Andrés Viernik, quiero comentarles que el próximo 28 de marzo, como parte de los programas de educación y academia del Hospital Metropolitano, vamos a tener el simposio Hospital Metropolitano 2023, en el que estaremos conversando de 3 temas: oncología, también enfermería y temas de pediatría. Esta es una iniciativa del Hospital Metropolitano y en la que queremos invitarlos a ustedes a ser parte de ellos. Específicamente en la parte de oncología estaremos discutiendo sobre tumores genitourinarios, trayendo a 3 especialistas de la Universidad de Chicago, el director del Departamento de Radiología, el doctor Ayekin Otto, el director del Departamento de Oncología Geniturinaria, Russell Celia Slumevitz, y también el director del Bladder Cancer Program, el doctor Piyush Agarwal. Les vamos a estar compartiendo en el chat el link de inscripción, pero queremos que nos acompañen el próximo 28 de marzo en el Santana Country Club durante la mañana con el enfoque enfermería y a partir de las 5 de la tarde en el enfoque de pediatría por un lado y de oncología en otro de los salones. Así que sin más preámbulo, me gustaría darle la palabra al doctor Andrés Biernik, director del Hospital Metropolitano, para que haga la introducción. Dr. Matthias Holdhoff, we're now switching to English. Vamos a estar hablando inglés. Buenas noches, doctor Biernik.
Muchas gracias a todos. Matthias, 1 second. I'm just going to say a couple of words in Spanish, and then I'll introduce you so you can start your talk. Muchísimas gracias a todos. Realmente para nosotros es un privilegio tener esta actividad académica. Realmente al final tuvimos más de 100 personas inscritas y la actividad se está grabando, entonces incluso aquellos que no van a poder participar de toda la sesión, vamos a estar compartiéndola con todos ustedes y siéntanse en libertad de compartirla con las personas que sientan que es de valor. Okay, Matthias, now it's our turn, so I'm going to try to do this in English. First of all, I want to thank you for your time. It's such a privilege to have you here, and I know you and I have become close friends over the last, 24 months or so, but reading your CV, I have it in my hand. You sent me 21 pages of a CV, which I'm very, very impressed. So I'm going to try to do my best to summarize it. It's really an honor to have you. As Alejandro said, this is our first expert talk of the year. And I think you've set up the bar really high as far as, the type of speaker that we're having. So really, I want to thank you. As I said in Spanish, we had over 100 people that confirmed to participate. We're going to actually be recording the session and we're going to share it. There's actually a few people also from Nicaragua and from El Salvador and Guatemala that are able to join. So it's really a privilege, and I really want to thank you for taking the time to talk to us tonight. Dr. Matthias Holdhoff is originally from Germany. He completed his MD degree in Berlin, in 2003. Then he completed a PhD as well in Germany, from which he graduated in 2005. He then moved to the United States, where he did his postdoc in 2002. Sorry, he was a student research fellow at Harvard University in 2002. Did a fellow in research at Tufts University in Boston in 2004, and then moved to Baltimore to complete his residency training, where he completed that at Johns Hopkins. He graduated from internal medicine and also did his fellowship in medical oncology from 2007 until 2010 at Johns Hopkins Hospital in Baltimore. Right now, he's the associate professor of the Department of Oncology and Neurosurgery at Johns Hopkins. He's associate professor of the Department of Oncology, Neurology, and Neurosurgery at Johns Hopkins. He's also the director of the Solid Tumor Inpatient Service at Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. He's the director of the Neuro-Oncology Fellowship Program and the co-director of the combined program of the Johns Hopkins University School of Medicine and the NIH, the National Institute of Health in Bethesda. He's also the co-director of the Brain Cancer Disease Group at Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. Dr. Holdhoff has published over 100 articles, which include not only original papers, reviews, editorials, letters to the editors, guidelines, expert opinions, etc. He's extremely amazing given his young age. I'm not going to disclose his age, but he's very, very productive. He has a lot of research funding as well. He has funding not only from the NIH. He has if some of us understand this language, he has an 1R21 grant where he's a co-PI. He's actually has been awarded the Breakthrough Cancer Award for research. He has several co-PIs and PI roles in multiple studies that are ongoing, and obviously has participated in multiple research funding studies as well. I'm not going to disclose the total amount, but he has over $1 million in research that he's been granted, and has been right now he's conducting studies in preclinical studies, also phase 1, phase 2, and phase 3 studies, all in the field of neuro-oncology. He's a member of the panel that writes the NCCN guidelines for brain cancers and part of the subcommittee for the primary CNS lymphomas and for systemic therapies as well. All of us who use NCCN all the time, you know, if you look for Dr. Holdhoff, he'll be right there on the first page. This is amazing. He's won many awards, you know, which we're very proud of you, Matthias, for moving the field, you know, in the right direction. In 2002, he won the scholarship for research at the Center of Blood Research in Boston, and European scholarship and exchange studies at Erasmus University in Paris. In 2005, he was awarded the Best Bedside Manner Award, you know, Johns Hopkins University. 2005, he was inducted magna cum laude in his doctoral thesis. In 2006, he got the second prize of the annual associate meeting at American College of Physicians in Maryland. He had a merit award from the Conquer Cancer Foundation in 2010, a Young Investigator Award in 2010, you know, also from the Conquer Cancer Foundation. He is the director. In 2013, he was awarded the Director's Teaching Award in Clinical Science at Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. 2017, he got the nomination for the Clinical Collaboration and Teamwork Award. And in 2021, he completed the ASCO, the American Society of Clinical Oncology Leadership Development Program. And in 2021, he was also awarded the Miller-Colson Academy of Clinical Excellence. For those of you who think that Dr. Holdhoff is only a superb clinician, you should also know that he's a superb musician. He's actually an avid cello player. I've learned that last year when I got to meet him. But it's amazing, you know, in 1991, he got the first prize of the National Music Competition in Germany. 1992, first prize at the National Music Competition in Germany. He's been very active in the music field and has gotten also many awards and participated in multiple orchestras. In 1991 to 1994, he was the member of the National Germany Youth Orchestra. And for those of us who like classical music, you know, he was also a substitute. I don't know what time, Matthias, are you doing all of these with all your work and research, but from 1998 until 2003, and again in 2018, he was actually a substitute for the Vienna Philharmonic Orchestra. Thank you very much, Dr. Holdhoff. The stage is yours. We have right now over 50 people that have joined. Thank you very much for your time, and thank you for teaching us and sharing your knowledge. It's really an honor to have you.
Well, thank you so much, Andres and Alejandro, for having me. I'm really embarrassed. The only reason why it's 21 pages is that's what you're supposed to do at the medical school when you come up for promotion. You put everything on there. As you can tell, I'm from Germany. I speak English with a German accent, so please forgive. And in Germany, if you submit a CV that's longer than 1 page, you don't get, nobody's gonna ever look at it. So I apologize for that, and thank you for this very, very kind introduction. I'm gonna try to share my slides. 1 second. Let me see if this works. So can you see my?
Yes.
Yeah, does this work? Good.
But we are seeing the presenter.
You tell this presenter. So I'm going to swap this. Display settings, swap. Is this better?
Yes, thank you very much.
Okay, perfect. So first of all, thank you for having me. And what I was hoping, and I was so glad to meet Andres at this class through ASCO last year. We were sort of like brainstorming. I mean, Zoom brings everybody close by, but there might be also opportunities to visit each other. And certainly, you know, Baltimore's not far from San Jose, and if anybody comes to visit, you're very welcome to come. And if anybody would like to talk about their research, you can always set something up. I'm going to talk about primary brain cancers. And why am I doing primary brain cancers? I'm a medical oncologist by training. I never thought I would do brain cancers. And I thought everybody who's doing oncology does leukemias, lymphomas. So I happened to have a thesis paper that had a glioblastoma cell line. There was a poster. And then I met mentor who was at Johns Hopkins and said, why don't you consider brain cancers? And then, one thing came after the other. So that's where what I'm working on. It's, of course, a field where there's a lot to do. I have a couple of disclosures, and I'm going to talk a little bit. I'm going to walk you through the current management of the most common primary brain cancers, which are astrocytomas and oligodendrogliomas. And my goal is to convey a little bit of the excitement in the field and the things that have happened since, let's say, over the last 20 years, and the many challenges that we still face. I will also talk a little bit about lower grade gliomas, because some patients might not require aggressive treatment upfront, could be observed for a while, and talk about some specific challenges in this field that are certainly of interest for everybody treating patients with this disease. On the other side, also researchers trying to overcome those hurdles. This talk is focused primarily on astrocytomas and oligodendrogliomas. As you can see on the upper left side, these are all the primary brain cancers, the malignant cancers. The vast majority are glioblastomas. The second most common tumors are actually oligodendrogliomas. So astrocytomas, the majority, oligodendrogliomas second. And you see here the distribution. Of course, the most common tumor in the brain that's not primary are metastatic lesions, and then you have non-malignant tumors as well. But the focus is really on malignant cancers. I'm starting with a very old case. And at the end, I'm going to ask the audience if you know who the patient might be. It was July 1937. The patient was playing the piano in the morning and went into a coma at night. He presented to Cedars Sinai Hospital, was then called Cedars of Lebanon Hospital in Los Angeles, had an abnormal neurological exam. There were not many neurosurgeons around that time. They called actually in Baltimore, Dr. Cushing, Harvey Cushing. They tried to ask if he could come to do a surgery. And he had retired. They didn't know that back then. Then they asked his predecessor, but he was, which apparently back then people did when they worked at the hospital. They took a little tour on the Chesapeake Bay, which is a really nice body of water near Baltimore. A lot of people go sailing, usually not the neurosurgeons anymore. And they did a ventriculogram, which we also nowadays almost never do. I've seen it one time. That showed a large right temporal lobe tumor. There was a cyst identified. There was dark yellow fluid. They removed what they call the nodule, and the surgery was 5 hours. The patient did not regain consciousness. It was called a spongioblastoma multiforme. Nowadays, it would be called a glioblastoma. We think it was probably glioblastoma of a young age, like a secondary glioblastoma. Does anybody have a guess who the patient might be? It's hard over Zoom, so I'm just going to disclose it was George Gershwin, who died of a glioblastoma at the age of 38. And had we had better treatments, we would have hoped probably much more great music to share. It's tragic, and we have so many patients who unfortunately die of this disease. I'm going to start a little bit with what could be sort of the last slide. I'm going to bring this up front. What is the survival in glioblastoma? And glioblastoma is the most common primary brain cancer in adults. In the year 2000, it was about 10%. And when I went to medical school, there was about one page in our textbook. It said, well, these tumors do poorly. You give radiation, and most patients die within a year after surgery and radiation. Well, then in 2005, we got the approval for the first chemotherapy, an alkylating drug called temozolomide, which is now a worldwide international standard. And the survival, the 2-year overall survival, and 2 years is a meaningful time point to look at patients with these high-grade gliomas. It went to 26%. And if you look at a certain biomarker, which I will explain in a little bit more detail, called MGMT promoter methylation, patients that were MGMT promoter methylated did better, and about 40% were alive. Out of a sudden, we're talking about a survival curve that looked pretty dire, and there was some hope that some patients could actually live a little bit longer. Since that time, we have not made a lot of progress, unfortunately, and I will illustrate that during this talk. So these tumors are widely infiltrated. They are, by the time we diagnose, by the time the surgeons try to resect what can be resected, they're often widespread. And we know from pathology data from earlier paper, the further you go in, you still find extensions of the glioblastoma. These tumors grow more like a meshwork than like a lump. And that makes it very difficult. So surgery is still the first step. Patients, if possible, we would get a gross total resection of the contrast enhancing disease, get as much out as possible. Some patients can only have a biopsy based on location, but you can never get clear margins other than other cancers where you can resect in the healthy tissue. You can, in these tumors, you never get everything surgically. Radiation is still the most important treatment modality after surgery. And then comes everything else. And the everything else is pretty much what we do as oncologists. We're working with chemotherapy, we're controlling symptoms, and we try to come up with new treatments, as does everybody else. I would say we are a big village of people treating these tumors, and we're working together trying to identify new treatments. The classification of these tumors and the understanding of their biology has significantly evolved over the last 15 years. And I'm trying to illustrate this in the next 3 slides. And if it comes across as a little bit confusing, it's because it's very confusing. And if you look at the WHO classification book from 2007, 2016, and 2021, it gets bigger and bigger. There was actually a neuropathologist recently put a slide together. He weighed the books, and it was like you could see the difference. So we understand more about the biology, but in the end, it will boil down to a few key markers that really define what makes a better prognostic or poor prognostic tumor. So this is what we used to think about. We use these terms, astrocytomas, like stars, astrocytomas being the more aggressive, more common tumors derived from astrocytes. Oligodendroglioma have few fingers, a little bit better behaved, do better. There was an entity that had mixed features when we looked under the microscope. So just pure histopathology was what was used to classify these tumors. Then came more and more molecular data, and it was new evidence that it's actually required for somebody who will have an oligodendroglioma to have a co-deletion of one PN19Q. That seems pretty random, but I will explain in a couple of slides why this is very relevant, and an IDH mutation. We still use grading. Low-grade tumors often show a relatively indolent growth. They are still cancerous. They still invade surrounding structures. However, they can sometimes, in select cases, and I will describe this later, be observed initially rather than treated right away. Oligodendrogliomas can become a grade 3. Astrocytomas can potentially become a glioblastoma. It is not as we thought. This is historical view. We know that it's more complicated, that there are more genetic events. So when we look at the histopathology, you can see that the oligodendrogliomas show a much more organized feature. So you can see here what is called the chicken wire appearance, and with a little bit of fantasy, you can see fried eggs. So this is like the classic fried egg appearance. I'm not sure if this really looks like a fried egg, but it sort of does. And even if they're high grade, they look a little bit more organized than glioblastomas. Here you see this chaotic picture. You see the central necrosis. The tumor grows so fast that it outgrows its own blood supply. The tumor is trying to build new blood vessels, and the tissues are more dense. So the clear difference here in histopathological appearance. We have learned since 2005 that these tumors can be subcategorized. And I'm going to take you through a little bit the history of neuropathology because it's very important. for the understanding of the behavior of these tumors, and then eventually of the treatment that we apply these days. Starting 2005, because 2005 was the first time we had a chemotherapy that showed in a randomized controlled trial a survival benefit in glioblastoma. That was the original data by Stubb and colleagues published in the New England Journal of Medicine in 2005. There was a companion paper showing that a epigenetic marker, MGMT promoter methylation, was associated with more benefit from chemotherapy. And now we know that this methylation marker is critically important to identify who will actually benefit from chemotherapy, who most likely will not. So this was our marker number one. And I promise you, there will only be 3 markers that are important. The second one, which sort of crystallized over some years, there were tumors that were oligodendrogliomas, so better behaving tumors. Remember the fried egg appearance, the chicken wire, and some tumors responded better to treatment, and people looked under the microscope and did karyotypes, and the karyotype analysis showed that there's a co-deletion of 1p19q, and that was associated with better response to chemotherapy and better outcome. So it was a prognostic and predictive marker. And then came the third marker, and it was actually when I joined Bert Vogelstein's lab at Hopkins for part of my training, that the week I was there, and I was so sad that I was not in the lab a little bit earlier, they published the association between IDH1 and glioblastomas. The initial paper was published in 2008, showing that 12% of patients with glioblastomas had IDH1 mutation, and that those patients were younger and did much better with treatment. The follow-up paper showed that this is a mutation in lower grade gliomas, both oligodendrogliomas and astrocytomas, and that patients who do not have an IDH1 mutation often have an IDH2 mutation. So that caused a lot of interest around the globe. There were numerous studies. Meanwhile, it was much easier and more cheaper to sequence. And there were several large studies, and virtually the neuropathology community worldwide put their heads together, tried to make rhyme and reason out of this. And they came up with the 2016 classification of brain tumors that for the first time integrated molecular pathology. We thought we were done with that. No, there have been updates, and the most recent classification, which actually boils down to something really simple and really neat, was the 2021 classification. And not only that the book is about 1,000 pages thick, but it actually boils down to the slide as it comes to gliomas. So now we only have 3 different epithelial gliomas that are really relevant to distinguish. So the first question that we ask is, does a tumor, no matter what it looks like under the microscope, have an IDH mutation or not? If it has an IDH mutation, it's either an IDH mutant astrocytoma or an oligodendroglioma. The oligodendroglioma, for that, it also needs the 1p19q codeletion. If a tumor doesn't have an IDH mutation, in the vast majority of cases, it is a glioblastoma. Even if it looks like a low-grade tumor, like a slow-growing tumor under the microscope, it will behave worse. The grading is still important. We say there are low grades and high grades for all of this, but the main tiebreaker now is this IDH mutation. So I'm just going to illustrate these biomarkers, and then I'm going to focus on a little bit more clinical relevant things. So, but these markers are important. The IDH1 mutations, they have metabolic importance. They create a oncometabolite called 2-hydroxyglutarate that leads to epigenetic modifications in the affected cells. These cells need the IDH to become cancerous, but they also lead to a more indolent or less aggressive phenotype. There are a bunch of mutations, and there are hotspot mutations there. This has been extensively studied, and we have now a target that we can develop new therapies for. And I will tell you in a little bit how far we have come so far, and there's way more to come, hopefully. The second one is this co-deletion of 1p19q. And this co-deletion of 1p19q essentially means that the tumor cells lose the short arm of chromosome 1 and the long arm of chromosome 19. So if there's a gene that's relevant for cell growth and regulation, and we lose one allele and the other one is mutated, this gene is switched off. We call this the Knudsen two-point hypothesis. And this is like, this disease actually works well to explain that. And this is important for the development of an oligodendroglioma. So now I'm going to focus on the most common primary brain cancers, high-grade astrocytomas, and especially glioblastomas. And the treatment schema that we use, and that is used worldwide for these tumors, is that we start with best possible surgical resection, or at least diagnosis or resection as much, followed by radiation. And radiation is typically given Mondays through Fridays, because the radiation machines don't work on the weekend. No, it's actually the radiation oncologists argue that it's actually not bad to have 2 days of break. Also, usually the hospital, the department might be close. And the chemotherapy is given every day, low-dose temozolomide, for 6 weeks for most patients, together with the radiation, followed by 4 weeks of a break, followed by 6 more cycles of chemotherapy. That was the original study, published in 2005 in the New England Journal of Medicine. That showed a survival benefit that was relatively modest. The goal was to improve the median survival meaning 50% of patients are still alive. At what time? By only 2.5 months. The goal was 3 months. So did this study fail? Well, yes and no. Was it an incredibly amazing therapy that revolutionized treatment? No. But did it change the standard of care? Yes. Because the curves really went apart, and there was, out of a sudden, we had more patients that lived at 2 years, 3 years, and we have some patients that lived much later. So this was a breakthrough. Modest, but a breakthrough. And we see here the progression-free survival curves, and you see that the curves eventually approach each other, meaning that there is that these tumors are still considered not curable, unfortunately. We do have some patients that live very long. Most patients don't. And the last marker, which is relevant for those, especially for the glioblastomas, is the MGMT promoter methylation. MGMT is the abbreviation for 0,6-methylguanine DNA methyltransferase. It's a repair enzyme. So when the radiation chemotherapy try to destroy tumor DNA, the body certainly tries to repair, which we do every day, every cell of our body. The MGMT repair enzyme needs to be expressed, and the expression happens through a gene promoter. And if the promoter is methylated or silenced, then the protein is not expressed. DNA repair doesn't happen so well, and the treatment works better. So nowadays, when we see a patient with a glioblastoma in clinic, one of the first questions comes up, often from the families that are by that time already very well read about the disease. Am I methylated or am I not methylated? And it has a big impact on survival, on outlook. So it's problematic, it's hard. And so patients, we get the results usually 2 to 3 weeks after surgery. If a patient is methylated, there's a much higher likelihood from response to therapy. Also, patients do better. And the difference is quite striking. This is the companion paper from 2005. You see here the unmethylated curve of unmethylated glioblastomas versus methylated. You can see there is a big difference between the curves, and that difference reflects more patients alive, more life, and a little bit better outlook. So I trained at Hopkins, and one of the reasons why I was like, oh my God, this is really cool, is that some of these biomarkers were actually developed. I was in Bert's lab. My colleague Will Parson was the first author on the paper, of the IDH paper. Chetan Bedegowda, we're still working together almost every day, neurosurgeon and the cancer geneticist. And on the other side of the floor was the epigenetics lab, and Jim Herman was the person who discovered the MGMT. For full disclosure, I have not discovered anything, or most of us. And so it's like, it was just a stimulating environment. So how do we improve on the standard of care? When we have for the first time a chemotherapy that improves outcome, the first thing, and as oncologists, we are very simple-minded. We say, well, if something works, why don't we give more? So the first thing was people tried 12 months instead of 6, or higher doses of chemotherapy. And all of that didn't really make a difference. So more temozolomide, there was a large study, multi-center study, comparing dose-dense chemotherapy, much more chemo, with standard chemotherapy. No difference. What about 12 cycles versus 6? There were 2 meta-analyses and 1 prospective study out of Spain that showed no difference in survival if you give more than 6 months. And the addition of other drugs, unfortunately, has not moved the needle yet. And that includes treatments like bevacizumab, Avastin. I will have a slide or 2 later. That was heavily discussed at conferences, in papers, but did not improve survival, unfortunately. What do we do at time of progression? And I'm not focusing so much on this during this talk, but I wanted to say that usually, because there's no uniform standard of care for recurrent disease, we go back to tumor board, we try to check all boxes. Is there a role for more surgery? Is there a role for repeat radiation? If the patient had a good initial response, if the location is acceptable for more radiation, could we challenge again with chemotherapy, or are there clinical trial options? And then came this, and let me tell you about this. This is a device that is now FDA approved for treatment of newly diagnosed glioblastomas. And as you can see here, this was actually a commercial by the company, and it was not a patient, it was an actor. But this is what the device looks like. Patients shave the head, wear this for 18 out of 24 hours, have a cable that connects to a battery box to carry on the back. And when we first heard about this in the brain tumor community, we're like, well, that sounds pretty crazy. And preclinical data showed that alternating electromagnetic fields can interfere with the formation of the spindle apparatus that's used to divide cells and promote tumor growth. So the idea was maybe it's going to work in some cancers, and it's now being tested. In glioblastomas, for whatever reason, which was the first disease it was studied first in recurrent disease. The data were not convincing us that it was actually working, because it was compared to standard of care options that we know don't improve standard of care as far as we know, and survival as far as we know. So the company then went to the newly diagnosed setting. After radiation chemotherapy, 4 weeks later, after the first MRI, patients would be randomized to receive the temozolomide alone for 6 months, or this in combination with the device. And to our surprise, the survival curves actually look better. The study has some challenges. It was not sham controlled, so patients were either wearing the device or not. If you were wearing the device, you got a little bit closer attention. You would also check on the computer how often am I wearing this, and so forth. But certainly there was a positive study. If this was a pill, we would probably say, oh yeah, there's a benefit, we should prescribe the pill. With this device, it's a little more dicey. It's also not so easy to take, to tolerate, and it's also very expensive. It costs, in the United States, costs $21,000 per month. Insurance companies tend to reluctantly cover this. It's FDA approved through the device committee. So we have a discussion with patients about the data. Most patients in our clinic don't choose to do it, some do. It does not, it could, we don't know, and we would like to have a sham control trial, but it will likely never be done. So what does it look like? So most data we have were in patients up to the age of 65, the original Stoop trial 70, what about older patients? And this is a disease of older adults. So there was a study in the New England Journal of Medicine, 2017, that compared short course of radiation, hypofractionated, three weeks with chemotherapy and chemotherapy after radiation chemotherapy versus radiation alone. There was again a survival benefit. And again, the MGMT methylation played a role. But you can see that overall survival was, as expected, worse compared to younger adults. And age and performance status are important prognostic factors. The study did not use 6 weeks of radiation. The rationale for that was that there was a study published by Roa and colleagues comparing when radiation was used alone in quote unquote older adults or elderly patients, 3 weeks of a little bit higher intensity hypofractionated with 6 weeks, and there was no difference in overall survival. So the idea was for patients with worse prognosis, giving a shorter course might be better tolerated. It's a little bit controversial. On the other side, we have some patients that would probably not be well served with 6 weeks. It's always a judgment call, and it requires a good discussion with the radiation oncologist and the team and the family. So I would say for astrocytomas, the glass is not even half full. Very different for oligodendrogliomas. And I'm making this distinction. I want to make it really clear that we now understand that oligodendrogliomas are a completely different disease. And even when I started my fellowship, it was still that we said, well, both are not great. Oligos do better than astros, but we didn't know exactly to which degree and how much better these tumors respond to chemotherapy. Oligodendrogliomas, and I go back to the slide where you can see the fried eggs and the chicken wire, pretty organized picture. I used a very trustworthy source here, Wikipedia, for this image, but it shows looks more indolent, right? And these behave more indolent. There were two large, very important studies that were done that define the role of chemotherapy, alkylating chemotherapy in this disease. Studies were done in anaplastic oligodendrogliomas or anaplastic oligoastrocytomas. Back then, everything was histopathology driven. Anaplastic means grade 3, means high grade. So they looked at high grade oligodendrogliomas. The standard of care was radiation. The studies, one study was done out of the Canada and the United States, gave 4 cycles of a chemotherapy called PCV. Not easy to tolerate, very myelosuppressive. And they gave a high dose of lomustine, which is here C, CCNU, followed by radiation. The other study looked very similar, was done in Europe, gave radiation and then PCV with a slightly lower dose of lomustine for 6 cycles. So we had 2 large randomized controlled trials in a relatively rare disease in 2 different continents. And the data, I'm just going to show you this slide as a punchline. For the first 7 years, there was no difference in survival. They published the data and said, well, it looks about the same, but let's keep watching. However, then the curves went apart. And if this was a very common disease, everybody would know about it. This is a rare disease, but the findings were striking. The Canadian study showed that overall survival doubled from 7.3 to 14.7 years. So it doubled. Patients on average lived 7 years longer with this disease. And if you look at the x-axis, now we're talking about years and years and years and years and years. In glioblastoma, we talk about a couple of months more, a couple of months less. Here we talk about years and years and years more. If we have a patient with even if it's a high-grade oligodendroglioma, we say you have a good chance of living, have a meaningful survival of over 10 years, 15 years, maybe longer. And the European study, the median survival was not reached. Now we know the curves probably didn't separate because some of these tumors were not adequately identified because the co-deletion was overreported. So the curves might look actually better. So what does this PCV chemotherapy look like? These are old drugs, lomustine. It has now been remarketed, same drug, just more expensive, called gliostine. But lomustine is highly myelosuppressive. It's a drug you give once every 6 weeks. Procarbazine is another alkylator. Procarbazine, if you give procarbazine, you have to avoid certain types of food. Unfortunately, everything that's good, milk, wine, chocolate, all of that, and caffeine can't do while you're taking procarbazine. So patients, of course, love that. And vincristine was given, which we know probably doesn't really get into the brain. We know if you give vincristine at higher doses intrathecally, patients die. But this was the regimen that was developed in the 1980s and was the standard of care when these studies were initially started. 6 weeks per cycle, up to 6 cycles, very difficult to control. Vincristine causes neuropathy. So the question was, why don't we use temozolomide, which is better tolerated? It's oral, but we don't have data comparing this. When you have 2 studies that show such a striking survival benefit, it's very hard to say, well, we think temozolomide is as good. We don't know. We looked at our patients, and for the first 7 years looks the same as PCV, but we don't know what it looks like in 15 years. So we have a study, international effort, to enroll patients with newly diagnosed oligodendrogliomas to randomize to radiation, PCV versus radiation, and temozolomide. There was another study that tried to define the standard of care for grade 3 astrocytomas that I will talk about a little bit later. So I'm going to take a step back. We talked about high-grade gliomas, and certainly if somebody comes in with an aggressively growing tumor, typically requires treatment pretty much right away. There are very rare incidents where we would initially watch carefully, but usually the treatment and the guidelines would say we would treat. Low-grade gliomas. Low-grade gliomas can be present years and years before diagnosis. Low-grade gliomas typically, most of them have an IDH mutation. Very often young adults, a typical presentation, young adult with, for example, with seizures, comes to the hospital, oh, we found a tumor. What are we going to do now? The tumor is usually non-enhancing on MRI. There were no good data to guide whether chemotherapy plays a role. There was a study performed over 20 years, comparing, again, the same thing, radiation alone versus radiation and PCV, this ancient regimen, which we all don't like, but we sort of use because it produced good data. Back then, nobody knew about these biomarkers, and because they were not discovered. And patients were randomized to low risk, and this was defined by the study as under 40 years old, and patients that had an excellent gross total resection. Those patients were observed. The others, and if you were just 40 or 41, you were on it, or had a less than a gross total resection, were considered high risk and were stratified risk, randomized to receive radiation alone or the combination. The data were interesting, were similar to what we saw in the studies for oligodendroglioma. There was a significant survival benefit from the addition of chemotherapy. However, when we broke it down, or when it was broken down by histopathological subtypes, you could see, as expected, oligodendrogliomas, these better behaving tumors with 1p92 codeletion and so forth, which was not looked at in the study, did much better. Astrocytomas, this was not yet statistically significant, but we know that the presence of an IDH mutation was important. So we learned a little bit. What did the study not answer? Is it okay to wait, watch and wait? If you're 41, would you be treated just because you're 41? No. If you have a tumor that's, even if it's not gross totally resected, you could watch and wait. And if you do serial MRI scans and the tumor is growing very, very slowly, you can sometimes buy time. And this study did not know about the subtypes at that time, so we don't have completely conclusive data. And we don't know how temozolomide compares to PCV. So there was a very important study out of Europe, and that was done in low-grade gliomas, lumped all the low grades together, like the oligos and astros. But it asked the question, do we need to treat right away, or can we observe? And the study had a really cool name, the non-believer trial. And the non-believer trial said, we don't believe that you have to radiate everybody right away after initial diagnosis. And the study showed that even though tumors continued to grow, and there was, of course, progression noted in the patients that were just observed, the overall survival was not impacted. This is important. Why is it important? Because let's say you're 20 years old, 28 years old, you come to clinic, you have a newly diagnosed low-grade oligodendroglioma glioma. Treating with radiation will always have some side effects, neurocognitive side effects, long-term side effects. If you can wait 5 to 10 years, that might be a good time to finish your degree, to work. So you're not compromising your survival while carefully watching. That's why these data were really important. So this was a lot of data, and I'm going to switch to talking a little bit about the challenges in the treatment of these cancers and the opportunities in terms of research. As you can see, we are far behind many other cancers in the way we can treat. We think about breast cancer, even lung cancer, and many hematologic malignancies. There has been much more progress over the last years, and we are not doing a very good job. And I will tell you in part why that might be, and why we need more and more people working in brain cancers to move the needle ahead and get us ahead in treatment of these cancers. The challenges in part lie in the presence of the blood-brain barrier. The blood-brain barrier, which exists for millions of years, protects us, for better or worse, from all kinds of toxins. It's a good reason it exists. It hinders drugs from getting to the target when we give chemotherapy or the drugs. So drug delivery is a major problem in treating these brain cancers. Lack of effective drugs. As you can see, the whole talk was a lot about biology, but not about a lot of interesting treatments. The tumors are pretty heterogeneous. When somebody has a glioblastoma, most patients have very different disease. It's all lumped under the same summary term, but now we do next generation sequencing in most patients, and we know that the biology of each individual tumor is a little bit different. The tumor microenvironment is different from other cancers. It is immunosuppressive, and we're learning more about it. We know that immunotherapies don't work so well in these cancers, or don't work at all so far. So that is disappointing. And these tumors have a relatively low mutational burden. These tumors are drug resistant. They have actually pumps that pump some of the chemotherapies right straight out of the cells. Once they're in, they're back out. And I think as an oncology community, we're not doing a very good job in advocating for brain cancer research. We say, like, well, let's try the new drug in every disease, but not in brain cancers. You know, brain cancers, we don't touch, they're so rare, and nothing works anyway. I think that's fundamentally wrong. And we think we need to involve more primary brain cancer patients in phase 1 clinical trials. And I think the whole field of oncology is moving more towards a basket approach. We look at which diseases fit a certain treatment, not so much which disease it is. And I think we're making some progress. And then we often don't really know how to really assess response and progression in these tumors. And that I will demonstrate in a couple of images. So the blood-brain barrier is tightly sealing these capillaries. And the majority of drugs, about 98%, don't cross the blood-brain barrier. Certainly in tumors, and in tumors where we see on MRI or contrast CT leakage of the contrast outside of the blood vessels, there's a disruption of the blood-brain barrier. So we have some areas of the tumor that might see the drug, but there are also areas that have an intact blood-brain barrier, and those are the areas usually in the periphery where the drug doesn't get. So blood-brain barrier is a real big issue. So are there ways to get around the blood-brain barrier, to outsmart it? Well, we can choose drugs that are lipophilic, that could make it through the membrane, We can try to loosen up the blood-brain barrier. There are techniques with focused ultrasound, as an example, creating micro bubbles that then break up the blood-brain barrier. Could we give implants? Could we give local regional chemotherapy, little wafers, for example, with chemotherapy? Can we do convention-enhanced delivery? Can we open the blood-brain barrier with osmosis? Can we give chemotherapy intrathecally, intranasally? There are many approaches. It is not very easy, but it's being explored. How do we know whether the drug gets in? This was my first crude paper at Hopkins. I had the naive idea of doing a study with imatinib, with Gleevec. Does it get into the brain? I wanted to do a trial, and then my mentor said, well, let's first see if it gets into the brain. We could see it gets into the brain, but it still doesn't have a very good effect. This was a not as sophisticated study as other studies that are done with microdialysis, where you put a microdialysis catheter into the brain and forms like an equilibrium with the extracellular fluid. You can measure disease concentrations locally. Now there are also imaging-guided imaging assessments. So when I started in oncology, I was fascinated by the first targeted therapies, and imatinib was just Gleevec. Imatinib was just introduced when I did my thesis, and I thought, oh my God, this is going to cure everything, right? We all thought, how cool is that? And then people had a couple of patients with a disease with an activating mutation. These were gastrointestinal stromal tumors. And then they had a New England Journal paper, and I thought, okay, that's something. We can do that too. And we tried to do this in glioblastoma, and we failed miserably. And when you look at all the different drugs that have been studied, it is not, unfortunately, not as easy. And in part it is because these tumors are very complex. If you switch off one pathway, there might be another one activated. And in most cases, with exceptions, and I will show 2 examples, the targeted therapies don't really work. It's a little bit like you want to go through New York, and you come from, let's say, the Upper West Side, want to go to Brooklyn, and one of the subway lines is blocked. You go to another subway, go another way, you know. We do have 2 targets that we are now working on. One is this IDH, and the IDH is not only predictive prognostic, it's also a potential target. We have initial experience with IDH inhibitors that show a slow regression of these tumors in low-grade gliomas. We have IDH mutation-targeted vaccines that are being developed, PARP inhibitors in combination with alkylating chemotherapy. Hypomethylating agents are a hypothesis, and glutaminase inhibitors and others. So now we have a target. Let's go for it. Of course, in 2 other cancers, this worked quite well, most notably in IDH mutant leukemia, where it's now approved, actually, interestingly, also in cholangiocarcinoma, that's IDH mutant. This was the first study where we looked at response to ivosidenib, which was the first IDH inhibitor. This was actually a patient of mine who had a tumor. It's a little bit difficult to see, but it went from blue to green to red over many years, grew, was a non-enhancing tumor. And then it went from blue to green to red on treatment. So now, many years later, the tumor is growing again, but radiation could be postponed by several years. Is this potentially interesting, meaningful? So there's a follow-up study, randomized controlled with another drug called vorasidenib, and we'll hopefully in the next 2 years, 3 years know what the benefit is overall. If you look at the growth pattern, these are 3 of my colleagues. This is David Campson, who's new in the faculty's interest in imaging, and he's a neuro-oncologist, neuroradiologist, Doris Lynn and Joe Latera from neuro-oncology colleague, looked at, so what does it look like when we give these IDH inhibitors? These tumors, sometimes they continue to grow, and then they continue to grow for a little while before they actually shrink. It's like very indolent growth. Sometimes these tumors grow so slowly, as if you look at a tree from year to year, you don't see the difference unless you look back at old pictures, you know. And similar is the response to these inhibitors. The other mutations that are really interesting are BRAF mutations in gliomas. And there were studies like just searching for what is BRAF mutant? What do we find? And some of the more rare, uncommon gliomas, also grade 1 in part, like, or some, we call them pleomorphic centroestrogen tumors, have a high frequency of BRAF mutations, which are targetable. And we know they are targetable because in melanoma, this has revolutionized treatment for BRAF mutant tumors, as well as in other cancers. 2% of our glioblastomas only are targetable. This is Carissa Schreck, one of our colleagues. She actually built her whole career on BRAF mutant brain cancers. And there are really cool data come out with, in part, relatively durable responses to dual inhibition with BRAF and MEK inhibitors. So there is some hope there. So these tumors are not very attractive to the immune system. The mutational burden is quite low. And we know that even in hypermutated tumors, the responses are meager. And then what do these tumors look like on imaging? How big is the disease? How much tumor is there? Here we see a brain metastasis. We know in brain metastasis, it's spread through the brain. Outside of this enhancing lesion, there's not much tumor there. This is just edema. But in a glioblastoma, for example, we see this enhancing area. We see some necrosis. We know there's tumor out there, but we cannot measure everything. So it's a real challenge. And then we have non-enhancing tumors. You see there's a tumor there, but how far does it really get? And imaging technologies become more sophisticated, but we're still often struggling with the question, is a tumor actually growing or not? And if we give radiation, do we have a radiation effect, or what we call pseudoprogression, or is it real tumor? An example where a treatment can also lead to significant confusion is Avastin or bevacizumab. Bevacizumab was approved by the FDA, initially preliminarily approved in 2009 for recurrent glioblastoma. The idea was it binds outside of the brain to VEGF, the vascular growth factor, and initially was not tested in brain cancers because people were worried about bleeding and all kinds of complications. Patients asked for it. Said, can we please try this? You know, we can't tolerate steroids, there's so much swelling. It was tried, and the radiographic results were impressive. But now we know that actually it does not improve survival, but the imaging looks dramatically better. And there were 2 studies trying to test whether there's an overall survival benefit. There was not. And there was a big disappointment. We saw that there was a little bit of a progression-free survival, but imaging looked better on Avastin, so we couldn't really use this as an endpoint. So this is an example of a quote-unquote response to Avastin. On the top panel, you see the glioblastoma, and you see it looks better. It's like, oh my God, great, right? It looks fantastic. The swelling goes down. This is the edema on the T2 flare image, much better. And over time, the tumor then grows and explodes. And survival studies, survival analysis in newly diagnosed recurrent disease do not show survival benefit, unfortunately. So what about gold standard for how we find out if something is progression or treatment effect from radiation? The gold standard was still to go back, do repeat surgery, and get a tissue diagnosis. But even then it can be confusing, because if you have disease that's treated with radiation chemotherapy, a lot of tumor cells die. The brain is trying to repair it. And you see like a mixed picture of sometimes like disease that is completely absent. And you say, oh, this is all treatment effect. Okay, great. The patient has not progressed. Great, let's continue with treatment. Everybody, big sigh of relief. We're doing good. Keep on going. Sometimes we see, oh, this is clearly active disease. Very often we see a little bit of treatment effect and a little bit of active disease. What do we do then? So we did this study. We sent slides, digitalized slides to 101 neuropathologists. And we put a Starbucks coffee shop gift card in it to ask if they could please fill out the survey to grade what is tumor, what is active tumor, is not active tumor. And this is a busy slide, but it should illustrate that the answers were sort of all over the map. So for some cases, some people would say it's progression. Others would say, I don't know. Some would say, I don't think it's progression. So we have now a working group with many neuropathologists and some oncologists mixed in, trying to come up with new criteria for progressive disease. This is a portrait of our research community. We're all in the same boat. We're all trying to do the same thing. We have a couple of people among us that are a little bit older experience. They have a lot of GIL or grant funding. And you could say the same in clinical work. We're all depending on each other. And it always takes a village to take care of our patients and get any projects off the ground. I hope I didn't talk too much. I think we hope we have some time for some questions. And I want to thank everybody who came today. Everybody's working in this field or who listened for me for so long, and especially Andres and also Alejandro Igea Alfaro and Hospital Metropolitano. Thank you so much.
Thank you, Matthias. Great talk and very, very interesting. We're gonna open questions to the group. You know, if you guys somebody wants to take the lead, feel free to either raise your hand or you can just type your question on the chat and I'm happy to read it for you while people get ready. I do have a question, Matthias. Well, and you alluded to these, that we know that these tumors unfortunately do not respond to immunotherapy, particularly checkpoint inhibitors. And even in those patients that have, you know, partial responses, interestingly, it doesn't even correlate with PD-L1 status, as an example.
Yeah.
But when you have done studies looking at, you know, how does the tumor look at the time of diagnosis versus how it looks at the time of progression, you know, it seems to me that very likely they're very heterogeneous in general. You know, there might be some no driver mutations. So in your clinical practice, are you, you know, first of all, if you have any thoughts on, you know, from a biology perspective, and second, are you checking, you know, are you sequencing tumors, you know, multiple times whenever you have access to these tissues, particularly in the GBMs, you know, or once you have a GBM, you know, that you have very well recognized at the molecular level, then you don't repeat those tests again?
Yeah, that's a great question. And it often comes down to resources. When patients are newly diagnosed, insurance usually pays for one comprehensive test that could be done through a company, Foundation Medicine, or one of these options. Or we do our house intern panel. At time of recurrence, we usually don't send the tissue again. There are certainly some patients who are trying to do this, trying to test for it. We are collaborating with our colleagues at the National Institute of Health. They have resources, essentially state-funded resources that are free, you know, for patients. So there we learn more about. We know that temozolomide can introduce more mutations. We can have hypermutated tumors at a later time point. It also doesn't correlate with response to immunotherapy.
Thank you. Alejandro Blanco is one of our radiation oncologists, and he's actually an expert in neuro radiation oncology. And his question, you know, is EORTC 22845 and 22844 were completed, you know, in an era where the technology on radiation therapy is much different than it is today. You know, how should we interpret those studies, you know, given the, you know, the better radiation treatments that we have today? He's asking a second question is, you know, nowadays we have different reports suggesting that we should escalate or intensify the doses of radiation in patients that do not have an MGMT mutation. So those are two questions.
Yeah, this is a great question. And honestly, as a non-radiation oncologist, I rely on the expertise of my radiation oncologists. So the two studies, so there was the non-believer study, which illustrated, which we often base on our discussions and which our radiation oncologists use as well. It's like, we can watch and wait. And as you said, it was based on older radiation technologies. We still use those data. I think biologically, it still does make sense to watch and wait for low-grade tumor. Dose escalation is being studied and discussed. And in standard practice, at least at our center, our radiation oncologists would not escalate the dose, but we have participated in a study that did It was an ECOG protocol, and Dr. Kleinberg, in collaboration with Emory University, did that protocol looking at a little bit altered fields as well as higher doses. I'm not sure to perfectly answer the question. I think the main question of watch and wait versus treatment later, I think is still valid. But I'm happy to discuss that more, or also we can certainly also can send this question further to our radiation oncologists.
Thank you. I think that would be terrific. Let me see if there's any other questions. I think people are a bit shy. I have another one.
Don't be shy. Everybody's shy. That's one thing. It's like the good thing is what I always realize is, like, whenever you're somewhere and it was always, as a student, and I'm very intimidated when there are smart people in the room, like right now, and I'm always surprised, like sometimes like these really famous people ask like questions that are so basic, and I was like, oh my god, I could have answered the question, but I would never dare to ask that.
Well, I'll tell you, we have some medical students here, we have residents, and we have people from different areas within the oncology and even non-oncologists, that are
also
joining
the
just for
speaker,
general learning.
Yeah, and the speaker in general, if the easier the question, the more happy the speaker. So if you can answer the question, I know.
I have a question on the studies on the low grade, and you very well alluded, at the PCV studies, looking at a much better survival, long term, in those patients that get, chemotherapy. Why is it that we have to wait so long to see a difference? That would be one question. The other one would be, indeed, those patients, they tend to do much better than those that do not get PCV upfront. But the other way of looking at it is, you still had a lot of people that died and didn't do well relatively early, right? I mean, so you alluded, I think, during the talk that, some of them were misdiagnosed, but so is that still the case, in more, considering the new, the new classification and how we're now able to, use genomics to classify this tumor better, or we still have a group of, patients with oligos that unfortunately are going to do bad, and we just don't know why.
So we still do have some patients with oligo features that do poorly, and for those, when we look at the pathology, there's usually something else that's fundamentally wrong with these cells. So we had one case of an 1p92 co-deleted, but not perfectly co-deleted case that we actually published. Was a case report. It was widely metastatic, went into tumor lysis syndrome, and we have some cases that are 1p19q co-deleted that for one reason or the other spread and behave very poorly and become leptomeningeal or get even outside of the brain. So that exists. I think the beginning of the curve where we saw these two curves together was a diagnostic challenge. We went back, actually, we were not part of the original study, but you can apply to the RTOG, which is this trial consortium. You can apply for the tissue as an outsider, which we did. It was politically challenging to get there, but then we did a study together with the investigators, and we sequenced the patients that did especially well and the ones that did especially poorly. It was way too late. We were over 10 years out, 10, 15 years out. But we could not find a distinct molecular feature that would differentiate those two groups. Some of the DNA was just too old to analyze.
Got it. Thank you. Another question here from Dr. Blanco. In patients with GBM and that relapse, and undergo new surgery, what is your thought on re-exposing those patients to Temorar, particularly in those that have a methylation on NGMT?
So in general, that's what we do. I mean, we have so little options, and honestly, at least in our group, we very often offer repeat radiation. Of course, not if somebody recurred within the first half year, but if somebody is over a year out and other options are not great, And if somebody was MGMT methylated, we would usually use temozolomide again. If somebody was not methylated, then typically not. And the debate is still, for somebody who's newly diagnosed, would you even give temozolomide if it's not methylated? We do it because we think there may be a small, very small fraction of patients might still respond. If we have a clinical trial that gives something else, it's often favored. In recurrent disease, yeah, I would say about half of our patients get repeat radiation. The ones with MGMT also get temozolomide again.
Mm-hmm. That's interesting. You know, when you were describing how sometimes your patients come to your office, you know, the first question is, am I methylated or not? Interestingly, I've recently encountered a patient who doesn't want to know. She says, if we're gonna do the same, you know, why should I know? You know, and I think there's value to that as well. You know, especially in our low resource settings like ours. You talked a bit about the pseudo progression issue. You know, could you elaborate more? Are you guys, are there's, you know, do we have any better imaging? You know, do you guys sometimes use something different than MRI? I mentioned this in particular. We had a case, some of us that are here, you know, very challenging case of a young lady who actually, you know, seemed to have pseudo progression after 2 cycles, 3 cycles on maintenance thermometer. You know, we gave her another 2 months, you know, and then, you know, again, you know, it was felt that she actually was progressing, you know, during, you know, early maintenance, and again, took her to the OR, and finally, you know, she did not have that progression. It was all pseudo, you know, so it was very challenging for us as a group. You know, we had reviewed the images in detail. You know, we felt that it was in her best interest to undergo surgery. You know, on one hand, you're glad that she did not progress. You know, we're actually putting her back on thermometer because she never progressed on it, and she still had a couple of cycles to go. But on the other hand, you wonder, well, we submitted this lady to an unnecessary surgery, right? I mean, is MRI your only tool? Do you have access to better imaging? Are there PET CT scans that are now using, you know, special radiosensitizers, etc.? I don't know.
No, that's a great question, and that's I think a big field of clinical research where our imaging folks are very heavily involved. So based on standard MRI, we try to order perfusion sequences that can provide some additional value, blood volume measurements. It's not 100% diagnostic. We have imaging protocols that are still investigational, but will most likely be integrated into our standard sequencing with APT, amide transfer protein imaging, APT imaging that correlates better with disease versus no disease. We sometimes do a repeat biopsy. Usually we try to reserve that for patients that would have a clinical benefit from repeat surgery, not just for diagnostic purposes, unless it's really, really pressing. In the case of a doubt, we tend to wait it out. We give
you just treat. You just continue, give steroids,
we continue
the maintenance, and then hope that they're not progressing.
Yeah.
Until it's
nobody knows,
obvious.
And we see pseudo progression sometimes very late. Yeah. And so the latest, I mean, we sometimes see it a year out, and sometimes we see, so especially in oligodendrogliomas, where, and we don't know why, probably because cells are still dying very late and there's necrosis late on. Sometimes a year or later out, we see areas that look like, oh my God, this is progression, it's not progression. And then you wait, and then a year later it's gone. Of course, in a glioblastoma, would be more concerning. The response criteria in neuro-oncology, or RANO criteria, use a 3-month window after completion of radiation. Anything that happens during that time, if it's within the treatment field, we sort of ignore. That said, what if something is there and after 4 months? It's not an absolute. So it's like it's for clinical trial purposes. We give this window that you would not come off trial if you have a quote unquote bad scan after your radiation.
I think Dr. Blanco had another one. In our current practice, you know, we're using PCV for oligos. We have seen terrific responses. Have you noticed pseudo progression in these cases? And I think you just alluded to that a bit in the oligo ones.
Yes, in the oligos, and sometimes really quite striking. And when we talk to colleagues, they all say, yeah, I've seen this and this, and you can show cases. It's pretty impressive. And that's, sometimes hard for patients, of course, when they come to clinic and they see the scan. And, or, what's even worse is now with electronic medical system, they get the report before they come to the clinic. And the report says, blah, 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 consistent with progression or high suspicion for progression. And that is really irritating. It's really hard for patients, Yeah, we also use PCV. I personally prefer PCV outside of a clinical trial because of the data, which is so strong. Some colleagues would not give the vincristine, would give PC because of the vincristine. They're concerned about neurotoxicity and also then doesn't really get into the brain. The data are so strong with PCV that typically I would start PCV, and then if there's a whiff of neuropathy, I would stop the vincristine. But we're doing exactly the same thing.
Okay, thank you. Let me see if there's any more questions. I think I want to be also very respectful. Well, if you're an hour, later than we are, and obviously I want to be respectful of your time.
No, this is incredibly nice. It's so nice, and I wish we could all meet. And again, if anybody comes to Baltimore, give me a call. Andres has my address, and also we'll certainly invite you over, Andres.
No, thank you. And actually, we have to bring you to Costa Rica physically, so you can continue to share your knowledge, and I think that would be terrific. There's one more question, Matthias, sorry.
Yeah.
In patients that have diffuse GBMs, diffuse gliomas in the half-line, of the brain, what is your recommended treatment in those circumstances?
Yeah, I think Dr. Blanco alludes to diffuse midline gliomas. So in the 2016 classification, there's a new entity. It's called diffuse midline glioma, defined by presence of a mutation called H3K27M. And those are initially were thought as, these are really bad. They can be worse than glioblastoma. Those are similar to the diffuse interpontine DIPGs in kids, where chemotherapy really doesn't help so much. There were a number of studies now that challenged that question and said, well, we could still use chemotherapy. There could be a benefit from. In adults, it's not as black and white. There's some patients do better. We give the same treatment as we would give for a glioblastoma at the present time. If there's a clinical trial, we try to get patients on. I have 2 patients that are adults now that are on a pediatric protocol with this drug called ONC201, and we just try to see if there's anything matching better, but usually we start with radiation temozolone. Okay.
Thank you. Well, I want to thank you again, Dr. Holdhoff, for your time. Very, very appreciative of everything that you're doing, and thank you for sharing your knowledge. I also want to thank everyone that has joined, and again, we'll be sharing the video. I think Alejandro will probably send this to everyone tomorrow, and I think he just wrote on the chat, you didn't get this, Matthias, but we're doing a cancer symposium, a live cancer symposium. This year, this will be our 4th cancer symposium that we're hosting in San Jose. And we'll be, but this, we tend to choose an entire topic. This year, we're doing it on genitourinary cancers. So unless you have an expertise in prostate cancer, all of a sudden, we would welcome you as a speaker. Otherwise, you're more than welcome to join us as a listening person, as I will be. And that's actually going to be on the 28th of March. And this year, actually, we're having the University of Chicago, who's sharing, some of their faculty, focusing on these GU cancers. So stay tuned, guys. We're going to be sending these save the dates this week, and we hope to see everyone there as well. Dr. Holdhoff, thank you very much. Buenas noches. Muchas gracias.
Buenas noches. Bye. Thank you so much. Bye.